Well, welcome everybody, and thank you for joining this webinar. Today's webinar is the first of three in our 2022 webinar series titled Managing Pediatric Prehospital Care. This series is being facilitated by Ohio EMS for Children and Nationwide Children's Hospital. Continuing education credit is going to be available upon completion of each webinar, and the CE attendance code will be provided in the chat box halfway through the presentation, and then it will be on screen at the end of the presentation. Myself, as well as our CE experts here at Nationwide, will be on at the end to answer any questions, and you can always email me after if you have any issues at annie.truelove@nationwidechildrens.org, and I'll put that in the chat as well. Today's webinar is titled Optimizing Pediatric Prehospital Seizure Management and will be presented by Dr. Manish Shah. Dr. Shah is a professor in the Department of Pediatrics in the Division of Emergency Medicine at Baylor College of Medicine. He is a site principal investigator for the Charlotte, Houston, and Milwaukee Pre-Hospital Research Node of the Pediatric Emergency Care Applied Research Network. Additionally, he is a pediatric emergency medicine physician at Texas Children's Hospital. In addition to being an EMS researcher, Dr. Shah advocates for enhanced pediatric prehospital care as the co-chair of the assessment work group of the National Pediatric Prehospital Readiness Project. He is board certified in pediatric emergency medicine and collaborates on educational and quality improvement projects with the Houston Fire Department. Thank you, Dr. Shah, for joining us. I am going to turn it over to you. And just a reminder to everyone to please keep yourselves on mute during the presentation, and the chat box will be open for questions and comments. And I am going to give you privileges, Dr. Shah.
Okay, I think I have them already.
Oh, you do? Great.
Yes, and let me get in slideshow mode and make sure you're seeing the slides and not the notes.
We are.
You are. Excellent. Okay, and then let me just make a quick adjustment to my screen. Okay. And you can hear me okay?
Yep, sounds good.
Okay, excellent. So it is a pleasure to be here today to speak to you about optimizing pediatric prehospital seizure management. Just to go over disclosures, I do not have any financial conflicts of interest relevant to this presentation. I will be discussing several grant-funded activities, and so I've listed the funding for those grant-funded activities here. All of them are from federal sources, either the Health Resources and Services Administration or the National Institute of Health's National Institute of Neurological Disorders and Stroke. And so for today's presentation, my objectives for you are, by the end of the presentation, I hope that you'll be able to identify areas in which EMS could improve the management of pediatric seizures, to summarize the major challenges that paramedics face in treating pediatric seizures, and to provide information about the pediatric dose optimization for seizures in EMS study, or PEDI-DOSE study, which will be taking place at 2 sites in Ohio, both in Columbus and in Cincinnati. So seizures are one of the most common medical reasons why EMS is called for a child, and it accounts for approximately 10% of all pediatric EMS transports based on various studies and our own EMS affiliated based data in the Pediatric Emergency Care Applied Research Network. When seizures are not stopped quickly, they can lead to neurologic morbidity, respiratory compromise, and even death. And timely delivery of the right dose of benzodiazepine using an ideal route is essential to effectively and safely treat pediatric seizures in the pre-hospital setting. So when we think about seizures, I think it's always good to think about a case. And so let's take this case. Paramedics are called to a park where a child's nanny called 911. Upon arrival, paramedics find a febrile toddler who's seizing. Paramedics cannot obtain a history due to a language barrier. Airway, breathing, circulation is stable. The scene is safe. And so what would be the next priority in managing this seizure? And I can't see the chat, so you can either say it out loud, since I can't see the chat.
And I can read it to you if
Yeah, that'd
something
be great.
pops up.
Okay, yeah, so yeah, go ahead and type in the chat. What would you do next in this situation? Scene safe, airway breathing circulation stable. This child's obviously having a febrile seizure. What would you do next? Annie, any responses in the chat?
No, silence in the
No,
chat.
silence. Okay, well
Oh,
then
here we
I'll.
go. Someone
Oh,
said
okay.
O2.
Okay, oxygen. All right. Other things when I've talked about this case example before, or just talked about febrile seizures before with EMS, is they've suggested other things like, okay, I'd start an IV, or I would check a blood glucose. I'd apply cold compresses to reduce the fever. I would give a rectal medication. And I see, I actually can see some of the things in the chat. And you've said some of these things that I can see popping up. So, but notice here, there's a whole variety of next steps that people are suggesting. And so when we look at seizure protocols, we see a lot of variation in seizure protocols across the country. And we know that when it comes to protocols in EMS, they can be created by opinion, they could be created by consensus. But when we know that protocols are created by the best available evidence, then we have an opportunity to enhance the protocols that we are creating and optimize patient care. And so back in 2009, the EMS for Children program and the National Highway Traffic Safety Administration came together to pilot test something called the National Prehospital Evidence-Based Guideline Model Process to actually create EMS-based protocols that were evidence-based using a process that was specifically designed with the intent of being EMS relevant. And so when they came together to do this, they focused on three clinical conditions, or three systems or clinical conditions. So one was specifically pediatric seizures, and I was able to work on that guideline development. The second was assessment and management of traumatic pain. And then the third was the use of helicopter EMS. And in that guideline that we eventually published in 2014, we suggested several things to do and several things not to do. And I want to call your attention to two of those things. One is the administration of something to do is the administration of intramuscular intranasal benzodiazepines as first-line treatment. And in the guideline itself, we didn't specify which benzodiazepine, but specifically here, I wrote midazolam in parentheses because midazolam can be given both intramuscular and intranasal. One other thing that we specifically said not to do was to place an intravenous line or an intraosseous line, because we know from evidence that contributed to that guideline development that it can lead to delays in care. And so you'll notice also, I'll go back a slide. You'll notice in that guideline, we also said to check a blood glucose. Now, if I were to rewrite this guideline today, I would make a modification. Back then, when we wrote this guideline, we didn't have very good data at the time about how often is an actively seizing child actually hypoglycemic. And so since then, we do have some evidence from several studies. And from those studies, we know that it's very rare for a child to be hypoglycemic when they're actively having a seizure in the presence of EMS. It's actually less than 2%. So there was an article, this is one of the articles that focused on this and found that the incidence in this study was actually 0.5%. This was done in Los Angeles County EMS. And so they actually propose a different approach in terms of priority of glucose checks. And so they said, if a child's actively seizing, really your first intervention, once you've dealt with scene safety and airway breathing circulation, is to give that first dose of midazolam. And then after you've done that, then you can check a blood glucose. And they also said that if the child is not actively seizing and their GCS is 15 or they're at baseline, then you could proceed with checking a glucose. When checking a glucose, they mentioned if it's normal, if it's been 5 minutes, then you can go ahead and repeat that second dose of midazolam. But if the child's hypoglycemic, then to go ahead and treat that hypoglycemia with either dextrose or glucagon per your local protocol. So if I were to rewrite that evidence-based guideline that we had written and published back in 2014, I would incorporate this as well in terms of flipping the order of priority and making glucose checks a secondary priority. So I also want to draw your attention to this evidence, and this is from the Rampart trial, which was a randomized trial of nearly 900 adults and children in the prehospital setting. And in this study, they actually compared intramuscular midazolam and intravenous lorazepam. And so in this study, what they did was they showed that although seizures stop faster once you give IV lorazepam, which is noted as B here on that top section of the diagram, they also found that when you give intramuscular midazolam, that the administration of intramuscular midazolam is a lot faster because there are delays related to IV placement. And so when you combine both the time it takes to actually get the treatment delivered plus the time it takes for the seizure to then stop, if you combine that, which is this middle part of the slide here, that really overall time to seizure cessation is actually shorter with intramuscular midazolam. And so for this reason, that is why we've incorporated that evidence into that evidence-based guideline to give a medication that's not by an IV route. Now, specifically in this study, they didn't study the intranasal route. There are other studies that compare intravenous and intranasal and show that the intranasal route is also effective. And so for that reason, in the evidence-based guideline, we suggested to either give intramuscular or intranasal benzodiazepines. And what you see here is that the percent of people seizing upon arrival to the emergency department was less when intramuscular midazolam was given. It was 10% less. Now, this study, like I mentioned, included both adults and children. In the entire makeup of the study, only 1 out of 6 people that were included in the study were children. And so there is a need to have more evidence that is pediatric specific on pediatric prehospital seizure management in the field. And I'll get to some of that evidence later and the opportunity to generate some more through a project that I'm leading. So despite having published guidelines, however, the relative infrequency of pediatric EMS cases compared to adults contributes to provider discomfort and variability in managing pediatric emergencies. And so there's still wide variability in how pediatric seizures are managed across EMS systems, such that those who work in EMS often say, if you've seen one EMS system, you've seen one EMS system. And this was evident to me in preparation for that research study that I'm going to describe to you later, when I gathered information on the 20 different seizure protocols from urban EMS agencies across the country, is that I saw a variety in dosing, a variety in routes of administration, a variety in maximum doses and priority. And so this publication here also highlights that variability, that there are variations in pediatric seizure protocols across the country in terms of what is incorporates model guidelines that have been published through the National Association of State EMS Officials, and what is required as mandatory versus not. And so there's a wide variety of what's out there when it comes to pediatric seizure management. And so to intentionally focus on knowledge translation for the seizure guideline itself, I actually incorporated that into another project that I was doing several years ago, where we had developed some other guidelines on airway management, anaphylaxis, shock, and spinal care. And we took some other clinical conditions for which we had evidence-based guidelines for children, including asthma, bronchiolitis, croup, and pain. And so we implemented these both in the Houston Fire Department in 2014, and then we also implemented them in several New England states in 2015. And specifically, just because you implement a protocol doesn't necessarily mean that change will occur. And so we saw this when we implemented this in Houston. So despite integrating the evidence-based guideline recommendations in Houston, we saw, specifically when it came to doing simulation training with our paramedics, and what was the use of other routes of administration, like intramuscular and intranasal, after paramedics had gone through that training, we saw that there was still a high rate of use of the intravenous route. We studied that several years later through 3 cities in Charlotte, Houston, and Milwaukee, where we implemented the guideline to see, is there a difference in several outcomes after implementing that evidence-based guideline. And so when we studied it in Charlotte, Houston, Milwaukee, we saw that there was good uptake, that the administration of the preferred routes of intramuscular and intranasal had increased. It went up from 50% when we'd studied it before to 77% after among the sites, that more children who were actively seizing were getting midazolam. There was an increase there, but we made this observation that approximately half of the children were getting the wrong dose. And when we dived a little bit deeper in that, we saw that 1/3 of these children were still arriving at the hospital, still having an active seizure, and that when we looked at the incorrect dosing, that more than 70% of these children were getting underdosed, not overdosed, when it came to those who got an incorrect dose. And that from the point of paramedic arrival on scene to actual administration of midazolam, there was a 14-minute time lag. And these are things that did not change before versus after protocol implementation. And so thinking about these things, there's clearly opportunities for improvement in how we're managing seizures, despite the fact that we actually have an evidence-based guideline that we've implemented. And so I think that, really understanding what's going on here, why is the management is still suboptimal? Why are the outcomes not where we want it to be? And so we broke down that process of, what exactly happens when a paramedic arrives on scene to manage a pediatric seizure. So with conventional dosing, as you know, paramedics have to first determine a patient's weight and then perform several calculations if they're using a length-based tape to estimate that weight. So they get the weight, they then determine, okay, which route am I going to use? What's the dose for that route? Make a calculation in milligrams per kilogram, and then convert that milligram dose into milliliters. And that's a several step process. Now imagine, for those of you who work in EMS, you know how this works. You're there on scene for a child. Now, granted, you take care of children as 10% of your patient population. So you can go perhaps many months without seeing a child. And then you're there on scene, have this critically ill child, emotions are high, risk is high, and then you've got parents there on scene who are upset and concerned, worried, think that their child's dying, might even be yelling at you, and then you have to do multi-step mathematical calculations. That's an error-prone process, and we decided to get the paramedic perspective on this by doing a qualitative study. We actually interviewed paramedics from all 3 of those cities, Houston, Milwaukee, and Charlotte, to understand what are the enablers to managing pediatric seizures per their protocol and what are the barriers. And some of the things that they brought up in these interviews were that in terms of enablers, things that helped follow their protocol were having point of care references that took away the need for dose calculation, and also the ability to provide medication by more than one route by having a choice. Some barriers that they noted were not having the right supplies there. So not having a mucosal atomizer or not having a small enough intramuscular needle to give an intramuscular injection to an infant, as an example. Also, they mentioned protocol ambiguity. So ambiguity among whether you treat a febrile seizure the same as a non-febrile seizure. Do you treat a partial seizure the same as a generalized seizure? Do you treat a pediatric seizure the same as an adult seizure? And so they offered some solutions to these barriers, which included simplifying the dosing among all routes of midazolam, having point of care references that actually match their protocols. Like, for example, like if you use a length-based tape, that length-based tape oftentimes is a commercial product. It's not matched to the exact medicine in your protocol. It might not be matched to the exact doses in your protocol. And so that can cause confusion. So they said that the point of care references should be matched to their protocols and to decrease that cognitive load required to calculate the medication dose. In addition, to address the barriers, they mentioned clarifying the maximum pediatric dose, since there was confusion about what's the most that they could give, and also clarifying which seizures should be treated. Do you treat a partial seizure? Do you treat a febrile seizure? Since there was confusion in their protocols about what to do in different situations. And then ensuring that the right equipment was there. So analyzing that feedback from paramedics to be in line with the evidence and address potential misconceptions, I propose this as a model protocol. That if you have an actively seizing patient, on the left-hand side, if only BLS is on scene, that you ensure scene safety, apply oxygen, and initiate BVM for apnea or ongoing hypoxia. Call ALS to meet en route if it's feasible and based on your distance to the hospital. Ask the bystander for the patient's age, and if it's not known, then go ahead and estimate that with a length-based tape. Check vitals as you normally would, including a blood glucose at that point. And if they're febrile, it's okay to give rectal acetaminophen if that's in your protocol, and remove excess clothing, but don't actively cool, since there isn't evidence to support that. But in terms of the scope of practice for BLS, in terms of managing the seizure, there are obviously limitations. But if ALS arrives on scene, you're going to go through a lot of those steps, but specifically after you've ensured scene safety, addressed the airway, breathing, circulation, and then gotten the age from the bystander, then really the recommendation I would make at that point is to go ahead and give intramuscular or intranasal midazolam and to use a standardized dose that's based on 0.2 milligrams per kilogram. And so what would that standardized dose be? I'm going to talk about that in just a moment when I talk about this research study that's going to happen in Cincinnati and Columbus, because we're actually going to study this. But if that seizure stops, then go ahead and transport it. If the seizure is continuing, then at that point check a glucose, treat it if needed, and then repeat a dose of midazolam if it's been more than 5 minutes since that first dose. And so what could standardized dosing look like? And so this is what I'm going to show you here. If we take what 0.2 milligrams per kilogram is, and we look at standardized growth curves for children at various ages, if we calculate that out into simplified dosing that could be administered if you're using the 5 milligram per ml concentration of midazolam, which most EMS agencies carry. Some carry the more dilute concentration of 1 milligram per ml. So this schematic only works if you're carrying the right concentration, because when you give an intranasal medication, as you probably already know, you're limited by how much volume you can give. So you can only give 1 milliliter in each nostril. So if you're trying to give these kind of doses, then you can't use the 1 milligram per ml concentration, because that'd be too much volume to spray in someone's nose, and also be a lot of volume to administer by an IM injection as well. So really, to do this, it would require using that more concentrated version, the 5 milligram per ml concentration. So what does this look like? I think about it like small, medium, large, or extra large. So if you're 6 to 16 months old, you'd get 1.25 milligrams, which is 0.25 ml. If you're 17 months to 5 years old, you get half an ml. If you're 6 to 11 years old, you get 1 ml. And if you're 12 to 13 years old, you get 2 ml. So now I say 12 to 13 because these are the age cutoffs we're using in this research study that I'm going to go into more detail about. But this would be an adult dose. So if you've gotten to being a 12 or 13-year-old, then you should be big enough to then get an adult dose. And I would recommend that adult dose should be a 10 milligram dose. So actually, let me go back a second. So, when I've shared these doses with people, sometimes there's concern because as I reviewed protocols from across the country, I see that the maximum dose, even for an adult, is sometimes less than 10 milligrams. Sometimes it ends up being listed as 5. And so I'll say that these doses have been studied before in children in both the emergency department setting and in the pediatric dentistry setting for sedation. And these doses are actually quite safe. In various studies that even go down to 1-month-olds, we see that when a 0.2 milligram per kilogram dose is given with a max dose of 10 milligrams, that the occurrence of adverse events is nearly absent. And if it did occur, it's usually because somebody got overdosed because they got the wrong dose, like they got a double dose, but by accident. That's what we see from the studies that have been published both in pediatric emergency medicine in using doses like this and in pediatric dentistry for sedation. So this shows you just a conceptual model for that pediatric dose optimization for seizures and EMS study that will be occurring in your state in both Cincinnati and in Columbus. And so what this gets at is some of the concepts that I was talking about earlier, that we have this barrier that there's this perceived need for intravenous access here. And we also have this barrier of, it takes a lot of mental effort to try to come up with the correct dose when you're dealing with a critically ill child and you've got worried caregivers on scene for a pediatric patient. And so to deal with both of these potential barriers, the perceived need for IV access and the cognitive load that it takes to make these calculations, by implementing intramuscular intranasal routes as the only routes that you give in the pre-hospital setting, and by standardizing the dose, as I just mentioned, that can really take away the delay of midazolam administration and also prevent the underdosing that's occurring that we know is already happening with managing seizures in the pre-hospital setting. And if we give a more timely dose and we give a more optimal dose, then that seizure ideally will not be occurring upon arrival to the emergency department. Because as you recall, what I mentioned earlier was that 1 in 3 of these kids currently, at least in that 3-site study that we did that had 533 actively seizing children, that 1 in 3 of those kids was still seizing upon arrival to the hospital. And so we know that when you have an ongoing seizure, that leads to neurologic morbidity that can cause brain damage when that seizure is going on too long. We also know that if you have an ongoing seizure, that you can stop breathing because that seizure is going on too long. Now, I've also gotten questions before about these doses and the concern for potential respiratory failure, that if you're giving the doses that I recommended, isn't that going to make somebody stop breathing? So, of course, if you give too much of a benzodiazepine, that can cause apnea. What we know from prior studies is that if you give 1 or 2 doses of a benzodiazepine at the doses that I've suggested, 0.2 milligrams per kilogram, that risk of respiratory failure is actually quite rare. What we also know from that study that I had done with 533 actively seizing kids is that already 1 out of 6 of these children experiences respiratory failure to the point that they need bag valve mask ventilation, supraglottic airway placement, or endotracheal intubation, either during EMS care or in the first 30 minutes of emergency department care. And so when you have this risk of respiratory failure already with current management, and you have this risk of neurologic morbidity, that can also lead to mortality. And so ultimately, that's what we want to prevent. And so our first aim in this study is to compare the impact of standardized EMS midazolam dosing relative to conventional dosing on pediatric seizure cessation. And we believe that by implementing a standardized protocol that uses standardized dosing that's age-based, that less children will be seizing upon arrival to the emergency department. In addition, the second aim of the study is that to compare the frequency of respiratory failure after implementation of standardized EMS midazolam dosing. And we think that by stopping the seizure faster, that we're going to have less respiratory failure, but although we're giving higher doses than have been previously given. So we think this will have a neutral effect in terms of that rate of respiratory failure being 1 in 6 currently. So who would be included in the study? In the Cincinnati Fire Department and the Columbus Fire Department. So and it will be 6-month-old to 13-year-old patients who are actively seizing in the care of a paramedic, regardless of seizure type or duration, and those who are transported by a participating EMS agency. So at your site, it would be, in your state, it would be the Cincinnati Fire Department and the Columbus Fire Department, and transported to any emergency department in the catchment area of those 2 EMS agencies. So we will not attempt to gather hospital data from patients who are transported to other emergency departments, but specifically for the hospitals that are affiliated with the study itself, we are going to actually get inpatient, in-hospital data on those patients as well. Now, I will highlight the age of inclusion. So when we first start the study, we are going to include all ages, but in terms of standardized dosing, we're limiting that to 2 to 13-year-olds. And the reason for that is we got some feedback from the National Institute of Health that, because in that Rampart study, they only went down to age 2 roughly, that they wanted to see more safety data, that it was okay to use standardized dosing before we went down in age. And so we have a data safety monitoring board for this study. They will be monitoring data on the patients that are enrolled in the first year, and then each year they're going to make a recommendation. If they recommend that we can decrease the age to a lower limit, then that'll happen in years 2, 3, and 4, as you see on the screen. So we have identified certain patients that should be excluded from the study, so from being treated under the protocol. So obviously, if someone has a benzodiazepine allergy, they shouldn't be subject to a protocol that uses midazolam. If they're pregnant, or if the paramedic thinks that they have a severe growth restriction, because then there would be a concern about using age as the means of determining the dose. And so in these situations, this is where either the protocol itself, as written by the medical director, will address what to do in those situations, or the paramedic would have to get in touch with their online medical director to determine what to do in those situations. There are obviously other things that are listed here that could affect the ultimate outcome of, is this child seizing upon arrival to the emergency department, or do they have respiratory failure? And so these kids can still get exposed to the protocol, treated under the protocol, but we're going to exclude them from the analysis. And so those are kids that have a traumatic head injury that's within 24 hours of the EMS call. They have a history of having psychogenic non-epileptic seizures. They're already on a ventilator. And so that means they have baseline respiratory failure. They ingested some sort of toxic substance that can cause a seizure, or they have a history, or they have absence seizures, either during EMS or emergency department care. So if those are things, or any of those things are noted, they would be excluded from the analysis. So this study will utilize something called emergency exception from informed consent. So this involves a potentially life-threatening, time-critical clinical condition that for which the standard of care is associated with a high failure rate. Although the study involves system-wide EMS protocol changes, waiver of consent is not appropriate based on communication with local IRBs. And so the investigators we're using a single IRB at the University of Utah, and then there is a relationship with all the institutional review boards, which are like the ethics review boards for research at each of the sites that are involved in the study. And really, sometimes people have concerns about doing a study that involves exception from informed consent. And the way I like to explain it is that the federal government has very strict guidelines of when you can use EFIC and when you cannot. And so this study meets all of the criteria in order to use it, which means that the condition has to be life-threatening. There has to be a prospect of benefit in what is being studied. Current treatment has to be suboptimal. it's necessary to collect data on the effectiveness and the safety of the thing that we're studying, which is the use of this standardized protocol. And there wouldn't be an opportunity to get consent because administering the treatment is time sensitive. And so really this treating seizures in the field meets all of those criteria. And in order to know what is the best treatment that's available, we have to do research on it to know. And so exception from informed consent has been used in other pediatric studies before in our own hospital. And these are studies that have been done as well across the country. We have studied two different things that involve pediatric seizures in the emergency department. And then that Rampart trial that I had mentioned as well used exception from informed consent and did include children in that study. So there is a precedent for doing exception from informed consent studies on children and in the pre-hospital setting and for seizures. So where will this study be done? It's going to be conducted in the Pediatric Emergency Care Applied Research Network. So that is a nationwide network that's funded by the Emergency Medical Services for Children program. And it has historically done hospital-based research, but for this study, this is one of few studies in the network that is actually going to focus on pre-hospital care. And so, as you can see here, we have collaborated with EMS agencies from across the country. Now, you'll see that many of these seem like urban agencies, and the reason why we focused on urban agencies is because we need the high enough pediatric volume of pediatric seizures to be able to answer our study question. And so using higher volume agencies is necessary to know if using this protocol is better than what's currently in place in existing protocols. So the PDDO study utilizes what's called a stepped wedge design among the 20 sites. So what that means is that every 4 months, we will stagger the implementation of this standardized protocol at sites. So what you see here is we're currently in this planning phase, which is noted in blue on the diagram. And then eventually, once we start patient enrollment, that is what's noted in yellow. And when we start patient enrollment, we're just going to start collecting data on what EMS agencies are currently doing. We're not going to change the protocol yet. But then every 4 months, we're going to let 2 agencies know that they're going to switch. And then once we do that, they're going to have 6 months of lead time to start planning for that, including a 4-month training period that's noted in T on the diagram, where they'll have the opportunity to train their paramedics in the use of the new protocol, and they'll receive education on pediatric seizure management, both online and in person, before they make the switch to that standardized protocol. Once they make that switch, that's where you see the gray on this diagram. So eventually, over a 4-year period, all 20 participating sites will make the switch from using the conventional approach, which is their existing protocol, to using the standardized approach, which is that standardized protocol using age-based dosing. Upon arrival to a study-affiliated emergency department, a research coordinator, if present, will also collect self-reported data from the paramedic that's not routinely documented in the medical record. So we're going to collect a lot of information that's routinely documented in the electronic record, but there are some additional things that are essential for the study that aren't routinely documented, like was the child seizing upon arrival to the emergency department, or did a bystander give benzodiazepines before arrival? And so these are things that are noted in red here on this slide. And so these are things that we're going to gather from the paramedic. And so if we don't make that in-person contact, then we're going to have a mechanism in place where we can have that data collection survey sent to the paramedic either by email or by text, or we can collect it over the phone. So paramedics already capture the majority of the data that we need for the study, as I mentioned, in the electronic record. For sites that don't have direct access to that data, that the agency is going to transfer that data to the research staff that's based at the hospital, and a research coordinator will go through that data. What we know from these participating sites is that the majority of these patients are going to get transported to one of these affiliated hospitals. So we estimate that about 75% of these patients are going to come to the local hospital, which is usually a children's hospital that's affiliated with the study. And so we're going to link these records based on identifiers like name, date of birth, and sex. But we're only going to collect EMS data on the patients that go to other hospitals. So what happens in the hospital for these patients? In the hospital, we're going to apply something called a rapid response electroencephalogram. And so this is going to be an objective way for us to know, is this child seizing upon arrival? Because what we know also is that somebody could be having a seizure, but it's not obvious. So we call that a subclinical seizure. So they may not have any outward signs of rhythmic movement or eye deviation, but they might be unresponsive and their brain is actually having a seizure, but you just can't see it. And so by using this rapid response electroencephalogram, then we'll have a more accurate way of knowing, is this child seizing or not? And we'll also gather information about clinical impressions from the providers that are there, the nurse and the physician that first see the patient as well. And we're going to have those rapid response electroencephalograms read by a neurologist so that we can get an accurate reading of whether or not the child was actually seizing upon arrival. So, so some take-home points of things I wanted to emphasize for you all is that intramuscular and intranasal midazolam should really be the first priority of treating a seizure once you've made sure that the scene is safe and you've dealt with airway, breathing, and circulation. Hypoglycemia is rare. It only happens in less than 2% of kids. And so deferring those glucose checks in your protocol until after that first dose of midazolam is given is really going to prevent delays in giving necessary treatment. In addition, focal and febrile seizures should be treated the same as generalized and afebrile seizures. So it's a myth that you have to treat them differently in the pre-hospital setting. So in the pre-hospital setting, if somebody's having a seizure, then give the medication. And then what we do know, though, is that there's a lot of variety in protocols out there. So although as part of the study for Cincinnati and Columbus in your own state, we're going to be modifying the protocols eventually. What you do in your own EMS agencies, if you're not at Columbus Fire Department or Cincinnati Fire Department, is really up to you and the medical directors in your agencies. And so I strongly encourage you to consider making modifications to your seizure protocols based on what I shared with you today. And so I intentionally ended a bit before our time so that we'd have time to discuss and happy to take questions that you have about this. What kind of questions do you have?
There was one comment in the chat box, and it says, I wonder if standing orders should change to not give benzo IV unless there's already an IV when the child begins seizing. I believe you're muted, Dr. Shah.
Oh, thanks. Sorry. I would recommend that modification in a protocol. We know, and this is true in adults too, we know from that Rampart trial that giving an IV benzodiazepine as opposed to giving it by another route, and specifically in that study, the intramuscular route, that the seizure is going to stop faster if you give it IM. Now, you brought up the situation of when, unless somebody has an IV in place already. So yes, if an IV is in place already, we know also from that study that giving the medication IV will stop the seizure faster if the IV is in place already. The majority of people for whom you respond for an EMS call, though, don't already have an IV in place, right? So so I would say that that would be a wise modification, and that really the exception would be, yes, if there's an IV already in place, then it would be okay to give an IV medication, but that would be the exception, not the rule.
And then,
Mhm.
sorry. I was going to read you a
Yeah,
follow-up question.
yeah, go ahead.
What is your opinion on ketamine for seizures refractory to benzos?
Yeah, so what we know from existing evidence is that once you've gotten 2 doses of a benzodiazepine, then really you should be going to what we call second line agents. And so second line agents in children are typically, based on the evidence, levetiracetam, fosphenytoin, or valproic acid. These three have been studied in children as second-line agents, and there are several trials that have compared all three of them and found no difference in them. Now, there are pros and cons of each in terms of how long it takes to give and potential side effects. And so what the evidence shows is that they're all effective: levetiracetam, fosphenytoin, and valproic acid. So really, those should be second-line agents. Now, when it comes to ketamine, ketamine is what's considered a third-line agent. So third-line agents would be starting somebody on a ketamine drip or a propofol drip or a pentobarbital drip or midazolam drip. Those are third-line agents. And so now I say all this, but this if we're talking EMS management, I'll give you the example of our study. In our study, only one site carries something that's not a benzodiazepine. Like one of the sites actually carries levetiracetam on the ambulance. That's quite rare. Now, if we're talking about in the emergency department, however, what I just said applies, right? Because you're going to have access to any of those medications likely. So once 2 doses of benzodiazepines have been given, then you should go to second-line agent, and the second-line agents could be levetiracetam, fosphenytoin, valproic acid. Our hospital, neurologists at my own hospital, they recommend giving levetiracetam of those three. But then if levetiracetam has been given, then usually neurologists will recommend giving another second-line agent if it's feasible to do so, like the child doesn't have allergies to the other medicine or things like that. So a lot of times we'll try 2 different second-line agents before we then go to a third-line agent. And that third-line agent, there's several options, like I mentioned: ketamine, propofol, midazolam, or pentobarbital. I can see the chat now, Andy. So I see a question. With febrile seizures, it was stated we should treat them the same. So is that meaning administer benzodiazepine prior to cooling measures? Yes. So while cooling can be a comfort measure in the setting of a fever, cooling has not been shown to stop the seizure, nor has giving preventative Tylenol or acetaminophen or ibuprofen. So really, if you're in the situation of you have an actively seizing child in front of you, whether or not they have a seizure, the treatment should be you give a benzodiazepine, and in most cases for EMS, that's going to be midazolam. Now, if you're in the hospital, because I know we probably have a mixed audience here of both EMS and in-hospital folks, if you're in the hospital, now you can give any benzodiazepine, diazepam, lorazepam, midazolam. They all work. I know that on the ambulance, there are some storage limitations sometimes with lorazepam because it's more temperature sensitive than midazolam and diazepam. And then in terms of routes of administration, midazolam is the most versatile. So I keep talking about midazolam, but I'm not biased towards midazolam. All three of those work: midazolam, diazepam, lorazepam. But when I'm talking about EMS, it's just you can give it by more routes, and it's a medication that's more easily stored in EMS. But in the emergency department, any of them work. And so, like, if you're in the emergency department and you already have IV access, it's fine to give lorazepam. If you don't have IV access, or it's hard to get the IV access, then you can do what EMS should do, which is give it intramuscular or give it intranasal. Okay, I see a question. Do benzos actually stop the brain seizure or just the muscular seizure? No, they actually stop the seizure. And this has been demonstrated with EEGs. So we do know that benzodiazepines actually stop the brain from seizing. Now, they don't always work, and so that's why sometimes you have to give a second dose. And sometimes even after that second dose, the seizure is still ongoing. And so that's why we call benzodiazepines first-line treatment, but then there are second-line treatments and third-line treatments if those other things don't work. Just scrolling through prior things when I was talking to see. Okay. What other questions do you have? I see there's some CE questions. Annie, did you want to address those?
Yeah, sure. I was just going to put it in the chat. With so many
Okay.
people attempting to get CE right now, the site is running pretty slow. So a couple options, you can log out and log back in and see if that works, or wait just maybe a couple hours until not so many people are trying to access the site. And then, of course, if you try again and it still doesn't work, please feel free to email me and we will definitely get you CE.